Okay, hello everyone. Greetings and welcome to this Cell-Press the Lancet webinar on cardiometabolic diseases. I am Ducle, the editor-in-chief of Med, a flagship medical journal by Cell-Press. This event is part of our celebration for the 50th anniversary of Cell-Press. In the next hour, we will hear from four distinguished speakers who will explore the pathophysiology of cardiometabolic conditions and discuss the latest therapeutic advancements. But first, why do we choose cardiometabolism as our topic? We know that metabolic disorders are intricately linked to various bodily functions, including cardiovascular and renal health. And collectively, they account for a significant burden of mortality and morbidity worldwide. We also know that managing obesity, for example, can effectively lower the risk of associated with diabetes and improve cardiovascular and renal functions. We owe our understanding of these connections to foundational research on cellular processes involving key molecules like insulin, glucagon, and glucotransporters, as well as to landmark clinical trials like the recent SELECT, STEPS, and SURMOUNT. The collaboration between Cell-Press and the Lancet for this webinar underscores our shared commitment to advancing medical knowledge. Thank you all for joining us, and I will now pass the baton to my colleague at the Lancet to guide us through this event. Chloe?
Hi there, it's fantastic to be joined by all of you on this webinar today. My name's Chloe Wilson. I'm one of the senior medical editors here at the Lancet. So I will be running our Q&A session at the end. So if you have any burning questions, please do put them in the chat and I'll be going through them as the webinar runs along. If you have a specific question for a specific speaker, please put that into the chat as well. So we'll have time for questions at the very end of the webinar rather than after all of the talks. But thank you so much for joining us. And just handing over to my colleague, David.
Hi, I'm David Holmes, Deputy Editor of the Lancet Diabetes and Endocrinology. The first speaker today is Alice Cheng, who's an endocrinologist and Associate Professor at the University of Toronto. And Alice is going to be setting the stage for cardiometabolic diseases.
Wonderful. So thank you very much, David, for the kind introduction. Thank you to Cell-Press and the Lancet for the opportunity to join this distinguished faculty and to present to you on this very important topic. So as David mentioned, I'm speaking to you from Toronto, Canada. So I'm going to say good morning to everybody, but also good afternoon as well as good evening, as we obviously have attendees from around the world. And my job at this point is to help set the stage, sort of the warm-up act, if you will, for the other faculty that will be speaking about more specific topics. So when I was given this, I sort of thought to myself, how am I going to approach this? But before I get into this, here are my disclosures. So the question was, how are we going to define cardiometabolic diseases, right? What exactly does that mean? And nowadays in 2024, if you have a question, what are you supposed to do? You could turn to ChatGPT. So I decided to turn to ChatGPT and ask it define cardiometabolic disease. And what it came up with was that it's a collective term, and I've highlighted the key words. It's a group of conditions that affect the cardiovascular system as well as metabolic processes. And they list heart disease, stroke, hypertension, type 2 diabetes, obesity, and insulin resistance. And the other key feature is the concept of common risk factors. But when looking at this, to sort of realize something was missing from the concept of cardiometabolic disease, and I think it's the cardio-kidney metabolic or cardio-renal metabolic, but the whole idea is that it's more than just the cardio and the metabolic, but there are other important organ systems that we need to include into this conversation. So with that in mind, I asked ChatGPT to define cardio-kidney metabolic disease. And here, a lot of similarities, but some important things to highlight is the concept of interconnectedness really came out in the first sentence in terms of its answer. Of course, cardiovascular, kidney, and metabolic processes. The concept of a shared risk factors was also highlighted quite strongly, as was the idea that these things were interconnected, a strong relationship, and the cycle of worsening health outcomes. So not only do these diseases exist together because of shared pathophysiology, but then problem with one exacerbates the problem with another, and then you create this vicious cycle. And I would add to that, the other importance is the fact that we have interventions that are going to be able to break that cycle. And I think that's the part, certainly as a clinician, that's critical for us to take home. Is this important or not? Now, Duke already mentioned at the beginning why this is such an important topic. And here I just took a look at the WHO leading causes of death as of 2021. Now, you'll notice that COVID has entered this list, unfortunately, for the timing of the 2021 look. In the 2019 look, COVID was not on the table yet. But globally, you can see that ischemic heart disease, stroke, diabetes, kidney disease, were all mentioned as issues that would fit into the cardio-kidney metabolic space. And then when looking at specific country types, so the middle to high income countries I show on the right-hand side, you see that stroke, ischemic heart disease, diabetes, hypertensive diseases are listed. If you look at high income countries, a stroke, ischemic heart disease, hypertensive heart disease, kidney diseases are mentioned. So these cardio-kidney metabolic diseases do in fact make the top 10 list, which is not a top 10 list that one necessarily wants to make. Now, if we take a look at the interconnectedness concept of cardiovascular, kidney, and metabolic diseases, you can see that on the top left, up to 60% of people with CKD will have cardiovascular disease, 30 to 40% of people with heart failure will have CKD. 1 in 3 people with type 2 diabetes are going to have cardiovascular disease, and a large percentage are going to have heart failure. And then up to 40% of people with type 2 also have chronic kidney disease. So there's this strong relationship between all 3 of these components. And any one of these can amplify the risk and accelerate the progression of the other ones. And ultimately, this leads to an increased risk of complications, but particularly mortality, which of course is very important. So the idea of early intervention and early recognition really needs to be emphasized for our patients. So what are some of these shared risk factors? So you see here in the box in the middle, overweight, obesity, adiposopathy, which I'll speak to a little bit more later, hypertension, dyslipidemia, smoking, genetics, environmental insults. All of these are shared risk factors that impact the cardio, the kidney, and the metabolic diseases. And then each disease state can then further exacerbate the others. This is just a sampling of some of those components. So starting with metabolic dysfunction, and here we're just focusing on pancreas. We'll talk about adipose shortly. But the lipoglucotoxicity, oxidative stress, endothelial dysfunction, the hyperglycemia itself. So if we go on the right-hand side, could then impact on the kidney part, and then kidney diseases with inflammation, uremic toxins, the sodium water retention, RAS overactivation, inflammation could then contribute to the cardiac part of things. And then abnormalities from the cardiac part of things, again, the common themes of inflammation, RAS overactivation could then feed into the metabolic, and you can see this vicious cycle that has then developed. But let's take a closer look at the overweight, obesity, and adiposopathy piece of things, and how does that contribute? So another metaphor that I've seen is this horticulture metaphor, and whatever tree you pick, you could pick whatever tree you want. And here we're going to pick the trunk of type 2 diabetes as the metabolic trunk. And from that trunk, it can bear fruits such as nephropathy. You could add to that retinopathy, neuropathy, but hyperglycemia, hypertension, dyslipidemia. And then if we take a look at the roots of the tree, there are many things that are contributing. Insulin resistance, beta cell dysfunction, genetics, of course, but you'll see that adiposopathy, or also known as sick fat tissue, is a significant contributor of the roots of this problem. And then because of these common roots, you can then develop other branches, and those other branches are cardiovascular disease, PCOS, sleep apnea, heart failure, MASLD, and the list can go on and on and on and on. So what exactly is adiposopathy? So adiposopathy is sick fat tissue, anatomically manifested by adipocyte hypertrophy, particularly visceral adiposity, as well as ectopic fat deposition. And white adipose tissue, although good for you, when it's unhealthily expanded, can then create the problems. And unfortunately, BMI, which has been the traditional measure of obesity or overweight, does not necessarily equal adiposopathy, and BMI can sometimes fall down when measuring that. And when we think about the fat cells themselves and how are they actually creating issue, I mean, fat cells, adipocytes, are necessary for health. And when they're normal, they do all the right things. So normal subcutaneous adipose tissue or visceral adipose tissue or functional brown adipose tissue, all of that is good. And you get preserved insulin sensitivity, reductions in inflammation, and reductions in cardiometabolic risk when it is in a healthy state. The issue, though, is when it's in an unhealthy state, when it's in fact hypertrophy and expanded, that you have increases, but particularly of the visceral adiposity and dysfunctional brown adipose tissue. And then you start to see hypoxia in the visceral adiposity, decreased angiogenic capacity. You start to see pro-inflammatory changes, immune cell recruitment, lipotoxicity, resulting in inflammation, insulin resistance, and that cardiometabolic risk that we are talking about today. So fat is definitely playing a very important role in all of this. So much so that the AHA, American Heart Association, in 2021 put out a scientific statement about obesity and cardiovascular disease. And just last year, the presidential advisory was on the cardiovascular kidney metabolic health. So a recognition of this interconnectedness and the importance of looking at everything together. And they defined it similarly, I guess, to almost how ChatGPT defined it in terms of pathophysiological interactions, so the interconnectedness about metabolic, cardiovascular, kidney, and the importance of adverse outcomes that come with that. So the concept here that there's interconnectedness, they may be separate at one point, then they come together, and early intervention is the real key that we really need to think about. So it's that concept of early investment, much like we tell people to do with money, to invest early at a young age so one can retire wealthy. I think when it comes to these concepts, we need to invest early in health and intervene upstream so that one can retire healthy, not just wealthy. So with that, I thank you for your attention, and I'm happy to pass the stage to the next presenter. Oh, David, we're not hearing you.
Thank you, Alice, for that great introduction. The next speaker is Caroline Apovian, who is a professor of medicine at Harvard Medical School and co-director of the Center for Weight Management and Wellness at Brigham and Women's Hospital. And Caroline is going to be speaking on weight loss and pharmacological management of obesity in 2024.
Thank you so much, and it's a pleasure to be here. I'm going to talk about the treatment of this disease that is obesity, and here are my disclosures. So Dr. Cheng really gave a wonderful introduction into adiposopathy and the increase in prevalence of cardiometabolic kidney disease. And I can think about, this is a graph that shows the prevalence of what we believe started the process to increase in dysfunctional metabolic health, starting in 1960, and this is in the United States. So in 1960, based on the BMI, we had many people, a good percentage of people were overweight with a BMI over 25, and obesity with a BMI over 30, affected about 10 or 11% of our population. And now in the latest numbers show obesity affecting 42.4% of American adults. And this is a quadrupling of the prevalence of obesity. Severe obesity with a BMI over 40 affects nearly 10% of our population, where it was almost very rare in 1960. So we can extrapolate that this increase in prevalence was not due to any genetic dysfunction, but is really due to something changing in the environment. And what has changed in the environment is certainly the easy availability of ultra-processed food. So we think that something in the environment has perturbed the pathway that leads to body fat regulation. And this is a schematic that shows in the middle here the hypothalamus with two sets of neurons that govern appetite and satiety, POMC-CART and PY, agouti-related protein neurons that, when activated on the right, lead to satiety, and on the left lead to hunger. And these neurons get afferents from the intestine after food is ingested, and also longer term from adipose tissue, which gives an idea of how much fat is stored in case of famine. And these are all genetically determined, and there are inputs coming from external sources: food production, social cues, the modern microenvironment of behavioral inputs that lead to healthy eating and exercise and sleep, and also biological influences such as early life events in the womb. And then on the right here, we also have other factors that are internal that affect this energy regulation system, such as brown fat, the microbiome, and muscle, all leading to perturbations of this energy regulation system that in the end regulates a certain body weight or body fat set point in this environment. And we think that over the years, something has perturbed this pathway in most individuals to lead to a defense of a higher body weight, at least in 42% of Americans. So let's talk about the treatment. We have treatments, diet and exercise at the top here, and then the various medications that have been shown to reduce appetite and also been shown to alter body dynamics so that energy expenditure may be increased and energy intake decreased. And at the bottom, we see the most effective treatment so far: bariatric surgery, the Roux-en-Y gastric bypass, and the sleeve gastrectomy are the most highly performed procedures in the United States, leading to about a 30 to 33% weight loss in less than a year. Now, there are some discrepancies here about the medications. Semaglutide, which was the first GLP-1 to be the second GLP-1 to be approved for obesity, gives you about a 16% weight loss. Tirzepatide is really a lot better than what is shown here. This comes from data in patients with diabetes. In patients with obesity, it's really about 22% weight loss down here. Here are the other medications that are available on the market for obesity treatment, and they're orals, whereas semaglutide and tirzepatide and liraglutide are injectable. So this is the current treatment landscape with the addition of tirzepatide, which was just approved last year. Tirzepatide giving 22.5% average weight loss, which leads it right in line with the more aggressive treatments such as the sleeve gastrectomy and the Roux-Y gastric bypass. This is not the grand finale. There are more effective meds in development, triple therapies and dual therapies. So these are gut hormone therapies, NuSH therapies, nutrient stimulated hormonal therapies that were developed after studying why the gastric bypass and sleeve gastrectomy are so effective for weight loss and weight maintenance. And it was found that it's because these procedures alter the secretion of these gut hormones to lead to the defense of a lower body weight. And they are now being combined to try to get at least an injectable treatment that would closely achieve the kind of weight loss that you can see with bariatric surgery. The clinical treatment guidelines are still the same today in 2024, which is that, again, we do define obesity based on the BMI, which is not, as Dr. Cheng alerted you to, it's not a great measure of adiposopathy, but it's what we have that is convenient and inexpensive. And so anyone with a BMI over 25 is considered overweight and should receive treatment with diet, exercise, and behavior change. BMI 27 and above with risk factors like heart disease, diabetes, osteoarthritis, GERD, should be apprised that a drug treatment option may be available for them. And then surgery is reserved for those extreme BMI categories above 40 or above 35 with usually sleep apnea or type 2 diabetes. And if lifestyle alone in the beginning does not yield results in a few months, you should really escalate to pharmacotherapy. And this is because obesity is now known to be a disease and not a matter of willpower. In fact, when you lose weight with diet and exercise alone, there are tremendous forces, some of the hormones that I mentioned, GLP-1, some of the other gut hormones, leptin, GIP, PYY, that really counter-regulate and really attempt to get the body back to the original body weight set point that the body is defending in this environment. Here is the efficacy of current and pending anti-obesity drugs compared to bariatric surgery. Again, we have the sleeve gastrectomy here with 25% weight loss, and the drugs that have been recently approved almost reaching that kind of weight loss and weight maintenance as long as you keep on the therapy, and retatrutide and CagriSema, both of which are in phase 3 trials, approaching 25% and more, which is really reaching and then superseding what you can get with a sleeve gastrectomy. And this is the placebo-subtracted weight loss achieved with semaglutide and tirzepatide. So if you would subtract what you can get with behavioral treatment alone, which is about 2 to 4% weight loss, you can see that what the drug is doing is a robust over 10% additional weight loss. Now, this study, SURMOUNT-4, was published last year, which showed what happens when you take tirzepatide and treat patients with a BMI over 30. What you get is a 21% weight loss in about 36 weeks. But then, and I'm unable to show you, but then when you re-randomize these patients, what I should see here, which I don't, those who are left on tirzepatide maintain that weight loss, and those who are switched to placebo regain weight. And that is proof that what these drugs are doing are altering the body weight set point, but must be maintained in order to see that weight stay off. So what are the multi-agonists that are going to be coming on the market, hopefully in a few years? GLP-1 was the first gut hormone that was discovered to alter body weight when given to patients. We have GLP-1 alone, which, as you know, is semaglutide, GLP-1 plus GIP, which is tirzepatide. We also have GLP-1 and glucagon being researched, other GLP-1 GIP moieties, and then we also have GLP-1 GIP and glucagon. We also have GLP-1 anti-GIP, and the story of GIP is very complicated, and we're realizing that both GIP and anti-GIP can assist in weight loss. Here is where these drugs, the past and present and future drugs work. They work in the brain. So this is truly, obesity is truly a neurometabolic disease. Potential actions of GIP and GLP-1, because they're analogs of naturally occurring hormones, they have receptors all over the body, and Dr. Cheng alerted to what happens when there is cardiometabolic disease in different areas of the body. And these agonists can have receptors in these different organs and can reduce dysfunction and metabolic dysfunction by exerting their effects on these cells, decreasing hyperglycemia, increasing insulin sensitivity, and even working on adipose tissue metabolism. The actions of, we're calling them GLP-1 medicines, even though they're really niche hormones and they're beyond GLP-1, but the next speaker will discuss how these medicines can also improve what we think, starting with inflammation, decreasing inflammation, to go and reduce some of the cardiometabolic dysfunction that obesity causes. There's a lot of support for the use of GLP-1 beyond weight loss and reduction in cardiometabolic risk that we will discuss, and on outcomes. And so the SELECT trial will be discussed, showing a 20% reduction in all-cause major adverse cardiovascular events with people on our GLP-1 receptor agonist semaglutide. Here it is. And this showed us a few years ago when it was published that we are treating, in order to treat obesity before it leads to these irreversible conditions and major adverse cardiovascular events, we need to start as early as possible. There's reduction in cardiovascular MACE events and also a reduction in the risk of developing diabetes. Now, in the last minute, I want to say that we are now realizing that obesity is a multimodal disease affecting all parts of the body and should be treated with a multidisciplinary care pattern. And I mentioned surgery. Surgery is still the most effective way to lose a significant amount of weight for those with extreme obesity, BMI over 40 or over 35 with a condition. How many patients are we talking about? We're talking about millions. 14, 15 million Americans have a BMI over 40. Only 250,000 procedures are done per year, which means that we have quite a ways to go. And surgical therapy can be combined with our newer medications to treat obesity that is recalcitrant to surgery. So we have patients who have achieved surgical weight loss to regain some weight years later, and then we have now papers that show that the addition of our GLP-1 medications can mitigate that weight gain, much as we have a restenosis rate after cabbages for heart disease and stent placement for angina. We have a regain weight for our definitive treatment for obesity, which is bariatric surgery. So about 20% of patients will experience weight regain after bariatric surgery within 5 years of their surgery. And there's new research showing that the use of new therapies is promising. The pipeline continues to basically use GLP-1 as the backbone, the first agonist that has been shown to promote weight loss. We are adding such hormones such as GIP, glucagon, amylin, and PYY to get more potent agents. So to summarize, 42% of US adults have obesity. About 1 billion people worldwide now have obesity. It's a complex disease of dysfunction between pathways of the brain and gut. It's truly a neurohormonal disease. And we are developing anti-obesity medications, approaching the weight loss of bariatric surgery, still considered the best treatment for long-term weight loss. Thank you so much.
Thank you, Caroline. Our next speaker is Naveed Sattar, who's Professor of Metabolic Medicine at the University of Glasgow. And Naveed is going to talk about the cardiovascular and renal protective effects of GLP-1 receptor agonists and SGO2 inhibitors. Over to you, Naveed.
The slides forward. So, Naveed Sattar, Glasgow. I'll move on. Next slide, please. So these are my disclosures. Next slide. I guess for these two classes of drugs, Alice, you actually started off talking about connectivity, but we started off with the GLP-1 and incretin class and SGLT2 inhibitors, and we had pathways by which we thought these would reduce sugar. We were not necessarily aware that these drugs may also have other disease-modifying benefits in terms of cardiovascular, metabolic, or renal disease. Next slide. However, based on sort of mandated requirement for cardiovascular outcomes, around about 2014, the EMPA-REG outcome trial was reported by Bernie Zinman and colleagues who I was with just now, actually. And since then, we've had about 5 major outcome trials with SGLT2 inhibitors in the context of diabetes, followed by trials in people with heart failure and kidney disease. And you'll see why when I show you the results. For GLP-1 receptors, we started off with a negative trial, initially ELIXIR, but since then, we've had multiple other outcome trials, most recently predominantly in diabetes, but most recently in patients without diabetes, as mentioned by Caroline, in people with coronary artery disease without diabetes, and the FLOW trial in kidney disease and with diabetes. Next slide. So in 2014, when I was sitting in the audience, this trial, EMPA-REG outcome with an SGLT inhibitor called empagliflozin, showed a 14% reduction in cardiovascular outcomes. And really, the audience was surprised because we were not necessarily anticipating that. We thought these drugs reduce sugar, but a 14% reduction in MACE was surprising. What was even more surprising was the 35% reduction in heart failure, hospitalization for heart failure, and a nominal, and you can see reductions in CVD death as well, which looked quite profound, which was, these results were really amazing. And one of the things I think we've all learned is scientific humility. These drugs have helped us uncover pathways between diabetes pathogenesis and outcomes that we didn't necessarily appreciate. Next slide. In terms of the GLP-1 class, the leader trial, so I can see at the top, the very top was the ELIXIR trial, which was negative. Since then, the leader trial then came out, showed a 13% reduction in cardiovascular outcomes. And since then, we've had a range of trials which we meta-analyzed, suggesting that the GLP-1 class lowers cardiovascular outcomes, MACE, by around about 14 to 15%. Again, really robust results, and something that perhaps wasn't necessarily anticipated when we started to do those trials. Next slide. And if you summarize all of that evidence, this is what it looks like in meta-analysis. So the SGLT2 class had a modest effect on MACE, about 10%. CVD death was more profound, MI about 10%, not really an effect on stroke, but most really interestingly, substantial reductions in heart failure hospitalization and chronic kidney disease. Whereas the GLP-1 class, more consistent reductions in the sort of atherosclerotic pathways, MACE, CVD death, MI, and particularly stroke, and people in the context of diabetes, and perhaps a modest effect in heart failure hospitalizations and CKD. Now, remembering most of these GLP-1s in these trials did not give big weight loss. So these were either lower doses of semaglutide or other GLP-1s like dulaglutide or albuglutide, which had very modest weight loss, typically less than 5%. But nevertheless, these were the results. The results, next slide, please. The results have been so profound that we've now moved on, and I'm not going to go through this in any detail, but we've now got trials in the context of patients living with heart failure, where most of the benefit is actually prevention of further heart failure. And we see that in people with diabetes. We also see in people without diabetes with SGLT2 inhibitors, which is amazing because these are drugs that were originally developed for diabetes, but wow, they actually prevent heart failure in people without diabetes. Equally, in the context of chronic kidney disease, in people with diabetes, prevent both renal and heart failure outcomes, and also in patients without diabetes, again, which is really interesting, they prevent renal outcomes. Next slide. The totality of the results is such that SGLT2 inhibitors and GLP-1 as a class, both classes, have got class 1 evidence for treating patients with existing cardiovascular disease and type 2 diabetes, such that they are now mandated, irrespective of glycemic levels in people with diabetes, and irrespective of whether or not the patients are on baseline metformin, for patients with high risk of existing cardiovascular disease or at high risk of cardiovascular disease. And I think that's a really profound change. The same is true in patients at high risk, and in some places in patients who have low risk of cardiovascular disease, perhaps less than 10%, which is what we put in this guideline in the ESC. But different. I think the kind of guidelines are broadly concurrent. Patients may start metformin first, but of course, nowadays around about probably at least 50% of patients have at least a high risk of cardiovascular disease by the time they're diagnosed, and will get put straight onto metformin plus SGLT2 inhibitor, or at least that should be the intention, and or GLP-1, although that generally doesn't happen because GLP-1s are currently more expensive and injectable compared to SGLT2s. But nevertheless, the level of evidence I've shown you has been so profound that these two classes of drugs have completely changed the guidelines in diabetes. The other 2 points I'm going to make is that the SGLT2 class data was so good that they then, with the trials in heart failure and kidney disease, this class of drugs has become foundational in the context of heart failure with reduced ejection fraction and HFpEF, and in chronic kidney disease. And I think one of the issues nowadays is no longer is the evidence good enough, is actually inertia and implementation. Next slide, please. Now, this is where I think we're not quite sure about mechanisms, but certainly what we've done over the last 25 years, we've done brilliantly at lowering atherosclerotic disease. We've treated LDL, blood pressure, aspirin. We've been less good at treating glucose, but we have targeted glucose, and we've lowered atherosclerosis, particularly in the context of diabetes and also people without diabetes. What we haven't realized is that there are pathways between obesity and sort of your pump and your filters that we fully didn't understand. And some of these include perhaps hemodynamic stress, perhaps cellular overnutrition, perhaps inflammation, and other pathways that are, and even perhaps ectopic fat aspects that we didn't fully understand, which are partially targeted. I think on the next slide, you'll see. Next slide, please. Partly targeted by SGLT2 inhibitors. They sort of correct hemodynamics. The GLP-1s will actually have direct effect on anti-atherosclerosis. And the hypothesis is that when you have GLP-1s or incretins that also have big weight loss, that not only will they reduce atherosclerosis, but by reducing ectopic fat or hemodynamic pressures, that they may also have benefits on heart failures and kidney outcomes. So there's a kind of a newer understanding of pathways between diabetes, excess nutrition, ectopic fat, and disease. Next slide, please. Now, Caroline's already mentioned the SELECT trial. It was a trial in patients without diabetes, but with cardiovascular disease. And this is important for two reasons, as Caroline mentioned. One, it took a higher dose of semaglutide than was trialed in diabetes trials, 2.4 milligrams, that gave greater weight loss, somewhere between 8.5 kilograms to 10%. So, 8 to 10% weight loss, but also tested it in the context of patients without diabetes compared to placebo. A big number of events, over 1,200 in over 17,000 patients. And you can see all the patients that had a BMI above 27, and as I say, they didn't have diabetes. So big weight loss, and you've already seen, next slide please, a 20% reduction in in MACE. And what's really interesting, if you look at the Kaplan-Meier, was a rapid separation of the curves. There's something going on with perhaps bigger weight loss than we saw in the diabetes trial that is more rapidly leading to cardiovascular benefit. Is that a stabilization of plaques? Is it hemodynamics? Is it because of a rapid reduction in blood pressure or an improvement in inflammation? I don't think anyone really knows. There were also nominally significant improvements in heart failure outcomes and in death from any cause. And there was also a reduction in all-cause hospitalization. Profound. Next slide, please. One of the other things I want you to pick up is if you look at the serious adverse events, yes, there were more adverse events linked to nausea and vomiting, but in terms of serious adverse events, they were actually significantly less in those who got semaglutide than the placebo group by around about 3%. So, and I suspect that's because many people who were on placebo, because they were having some of the serious adverse events linked to their obesity, which semaglutide partially corrects, that they were attributing to the drug, but it was actually probably linked to their obesity because clearly these patients were on placebo injections. Next slide. And we saw the same thing in FLOW and STEP-HFpEF. And in terms of STEP-HFpEF, giving the same dose of semaglutide to patients with heart failure with preserved ejection fraction, around about 10 kilogram weight loss, but a profound improvement in how patients felt. This is called a KCCQ, which is the kind of heart failure questionnaire, improved by about 8 units, which is more than we see with SGLT2 inhibitors, and was somewhat unexpected. And it looks like it's predominantly weight loss. There's some debate about this. And within this trial and its sort of sister trial in diabetes, there was lower number of hard outcomes as well. People still argue whether it's the direct effect or whether it's weight loss. I happen to believe certainly the symptomatic benefit is probably the weight loss. Whether the outcomes is also weight loss, plus or minus some of the SGLT2 direct effects, is probably not quite sure, not quite certain. Next slide, please. And then FLOW is a trial of semaglutide at 1 milligram, and at top line is semaglutide 1 milligram in the context of diabetes lowered major first kidney outcomes by about 24%, I think. Also lowered cardiovascular outcomes and lowered death from any cause by 20%. And all of these are really profound results that suggest that in kidney disease, now we're going beyond ACE inhibitors and ARBs, and we've now got SGLT2 inhibitors, and coming with that now will be GLP-1 receptor agonists, particularly semaglutide, because it has the evidence in this context. So the last 2 or 3 slides, just to summarize. GLP-1s lower CVD in diabetes and non-diabetes. The ASCVD benefit for this class is predominantly, probably largely independent of weight loss. And I think it is predominantly the direct effect of the drug on tissues. The overall effect is modest. It's about 15 to 20% compared to statins. If you lower your LDL by 2 millimoles, you will lower your risk of heart attacks and strokes by 40%. However, this is important though, because this class of drugs, not particularly at higher dose, has a large intentional weight loss of about 8 to 15%, has a CKD and heart HFpEF benefit, lowers blood pressure, quality of life is improved, and you got less serious adverse events. Plus, you get benefits on liver outcomes, sleep apnea, and OA. So the weight loss, in part, is giving substantial other benefits which patients want, and they feel better, and you get less serious adverse events. And this is not something you see with many other classes of cardioprotective medicines. And many patients are voting with their feet and requiring and demanding that they put on these drugs for this multitude of reasons. The big problem, however, in many health systems is that we can't afford to treat the number of individuals eligible for the drugs. But we also cannot afford not to treat those individuals. So there's big voices in both directions. The demands are huge, and really, this is, I think, some of the questions that I suspect will come up to now. Finally, there are ongoing trials with drugs that give even bigger weight loss than semaglutide, tirzepatide, survodutide, CagriSema, and these ongoing trials will tell us more about the impacts of these newer classes beyond GLP-1 and GIP, but also give you bigger weight loss. And we're going to learn a lot more about the impact of intentional weight loss plus these molecules on a range of cardiometabolic, kidney and liver outcomes going forward. And these current results added to the new results are really likely to change guidelines in a huge way, but big issues in terms of cost and how we get patients on these drugs safely, and all the long-term aspects will be picked up in questions. Next slide, I think, is my final slide. Oh, no, the last couple of slides. And these things are important because atherosclerosis, as I say, has been coming down, but all the non-atherosclerotic cardiovascular outcomes that are going up are partly linked to obesity and aging. And that's a recent paper by Natalie Conlon. And I'll finish with my final slide. And sorry about the little blip at the beginning. Overall summary, SGLT2s prevent CKD, heart failure, and MACE. And they're now first or second line in diabetes and foundational in the context of kidney disease and heart failure. GLP-1s reduce MACE, kidney disease, and HFpEF symptoms. In patients without diabetes, semaglutide reduced MACE and probably not weight independent. However, the benefits go well beyond ASCVD. We think they correct hemodynamics, mimic starvation, hypoxia for SGLT2s, and there are many other benefits of GLP-1s as well. And I'll stop. Final slide, please, and we'll pick up in questions. I'll leave you with my dog on the back in Benan in Scotland, and thanks to my colleagues in Glasgow and worldwide who I continue to enjoy working with. Thank you very much.
Thanks, Naveed, for that great talk. We're now going to move on to the challenges that these new effective treatments present in terms of availability and access. And Professor Susan Jebb, who is a professor of diet and population health at the University of Oxford, is going to lead this discussion.
Thank you very much. I was asked to start really the discussion by setting out some of the questions and the challenges that we need to consider in this new era of pharmacotherapy to treat obesity. I'm conscious that in doing so, I might sound skeptical about the value of these drugs, and I am not. As we've heard, they're very effective treatments to reduce the burden of ill health. And I think we can expect to see a very rapid expansion in new drugs, in the indications for these drugs. The costs will decrease and more people are going to benefit from them. So I'm a great supporter of these treatments for people living with obesity, and especially those with these established comorbidities. But as with any new sort of breakthrough, we all tend to suffer from a degree of optimistic bias about the difference that this new technology will make. And I think we will make better progress if we actually start off by being a bit more realistic about some of the other issues we face. So firstly, and Naveed touched on this, we need to think about the rollout of these treatments. So here my views are very strongly coloured by the UK situation, but I imagine will resonate with people in other countries too. Many clinical guidelines are not fully implemented, and it's pretty hard to imagine that for these drugs will be any different. I think there are also more barriers than usual, not least the sheer number of people who are now talking about potentially treating with these agents. If we look at obesity treatment at the moment, it's patchy and really grossly inadequate. So we're effectively going to be asking the health system to take on a whole load of work that it isn't presently doing, and with no extra resource, and that is pretty ambitious. In my own research, we've seen quite marked ambivalence among some general practitioners, family doctors, about treating obesity and the role of these new drugs. Doctors know they're going to have to prescribe, monitor and manage this care, and they worry they're going to be taking on responsibility for a chronic relapsing condition. They know it's not just about writing a prescription. It's also about how they're going to provide the behavioural support that goes alongside these drugs. If we look across the spread of the semaglutide STEP trials, it's very clear that if the drugs are given alone with no behavioural support, you get less weight loss than if you have a combined package of drug and behavioural therapy. So I think there are real questions to answer about whether the system is able to take on that job of providing behavioural support for millions and millions of people. Even if we can offer care to everyone who might benefit, these treatments are not going to be the answer for everybody. We need to remember that trials select people who are keen to try medications, but lots of people don't want to take medication. People with diabetes often want to lose weight to come off their diabetes meds, not to swap one tablet or injection for another one. Some people do experience unacceptable side effects and they quickly stop treatment. Other people continue whilst they're losing weight, but think again when their weight plateaus. And we know from other conditions that in general, medication adherence in the long term is often poor. My next point is that, as Caroline noticed, weight regain when treatment ends is marked. A small proportion of people sustain long-term losses, and they're actually amazing individuals, but the majority of people will regain the lost weight, and at a rate that seems to be faster than after the end of behavioural weight management programs. We're just wrapping up a systematic review on that. These drugs turn down the hunger drive, so there's less need for people to learn the cognitive strategies to curtail their appetite when the treatment ends. So I think in initiating these treatments, we also need to be thinking ahead about how best to support patients in the longer term. The reality is that behavioural interventions for long-term weight loss maintenance have actually been rather disappointing. So people have tended to argue that these medications should continue forever, just as we manage other risk factors like blood pressure. But I think we then need to recognise the challenges of adherence, but also the financial consequences of lifelong therapy for potentially millions and millions of people. Will those who are self-funding continue to pay? Well, the early data from the US suggests many will not. And will insurers or publicly funded healthcare systems be prepared to treat people for life? I think it's more likely we will need to consider pulsed treatment or rescue therapies. But then will a second course of treatment achieve the same result as the first? We don't know that. But we need evidence on how these medications can be used in a way that's going to be most cost effective. And indeed, we need to understand whether or not they might be a better option to bariatric surgery when considered over a lifetime. So that brings me to issues of cost and equity. At present, these drugs are largely the preserve of wealthy people in wealthy countries, people who have generous insurance schemes or who can afford to pay themselves. In the UK, we hope that our publicly funded NHS will roll this out nationally, and that will help to reduce current inequity. But at the moment, whilst availability is limited and where treatments are not offered routinely, what we see happening is that people who are best able to navigate the system and advocate for their treatment of choice are going to be the best served. And if we think of this at a global level, the inequity will be very much greater. Health systems with very limited funding and grappling with the double burden of over and undernutrition are going to struggle to offer these treatments. So I think we need to recognise that this is likely to exacerbate existing health inequalities and think how we can mitigate that effect. Moving on now to some of the broader societal implications, I just want to think for a moment about how these drugs might change the narrative on obesity, for better or for worse. For some time now, we've had a concerted push from the pharmaceutical industry to define obesity as a disease. I'll be honest, my personal view is that that isn't helpful to medicalise a large proportion of the population. I think of obesity as a risk factor, not as a disease, and obesity is a perfectly normal response to a very abnormal environment. We live in a world that bears little resemblance to the world in which we evolved, where food was scarce and the energy cost of acquiring it was high. What's remarkable to me is not that people are overweight, but that actually we aren't all overweight. So if drugs become the norm to treat people with obesity, there's little doubt in my mind that that will move us a big step further towards the medicalisation of this condition. The benefits, we're told, is that it will reduce weight stigma. I haven't actually seen any direct evidence of that, and I just note that many diseases remain highly stigmatised. Think of psoriasis, for example. For people who are living in much larger bodies who experience the most marked weight stigma, even if they lose 15% of their weight, it's unlikely to relieve them of the physical manifestations of excess weight, which is the root of so much of the weight bias. Alongside, I think there's also a growing body of qualitative research on the stigma which is associated with weight loss medications themselves. People report that they avoid discussing their medication because of the negative reactions they receive. They tell us that when they say they're losing weight with the support of a drug, it's perceived as cheating in some way, and that it reinforces an unwarranted stereotype that people who are living with obesity are somehow too weak-willed to lose weight themselves. And the effect of that is to enhance their feeling of shame. Some people think that as these treatments become more normalised, weight stigma will subside. But if we look further ahead and more people achieve and maintain a lower body weight, what does that mean for the weight stigma experienced by people for whom these drugs are not an option? And then just finally, what does this new era of drug treatment mean for obesity prevention? I hope that the one thing we can all agree on is that prevention would be a much better option than treatment if, and it's a big if, we could make this a reality for the population at large. It'd be better for people, better for healthcare systems, better for our economy. But if we want to deliver that, it means investment in large-scale public health policies. Policies that lead to a healthier food environment and real opportunities for physical activity. Opportunities that don't rely on individuals having the material or the cognitive resources to specifically seek out a healthy, active lifestyle. I think we have to recognise that prevention and treatment of obesity are both about improving long-term health, and they should be working in tandem. But often we see them pitted against each other. And I do worry a little bit that while attention's focused on very exciting medtech solutions, there's a real risk we turn our back on the need to put the guardrails around the actions of the food industry. So I guess just in conclusion, I'd say that the burden of established obesity and its comorbidities is so high that we absolutely must welcome these drugs as a very important new tool. But we also have got to find ways to deploy them that are cost-effective, sustainable for healthcare systems, and equitable for societies. And I think as they roll out, we also need to look beyond the drugs themselves and think about the dynamic ecosystem into which we're launching them. And the complexity of that should absolutely remind us that we really, really need to redouble our efforts on obesity prevention. Thank you.
Thank you ever so much, Susan, for those thoughts and reflections. I certainly have a lot to reflect on after that talk, but perhaps if all of our speakers would very kindly be able to turn their cameras on, that would be great. So we are running a little bit over, but we still do have time, I think, for around 7 or 8 minutes of discussion. So I guess I just wanted to start before we go on to some of the audience Q&A to ask if anyone had any specific reflections after Susan's talk. I mean, one of the things that I was thinking about is, in reality, how feasible do we think it is to implement sort of the new pharmacotherapies within the current landscape of obesity treatment? And perhaps that one could go to Naveed, because I can see you on the screen first.
Thanks, Chloe. I guess the biggest issue at the moment in terms of these drugs is their cost, actually. The costs are, the number of who potentially stand to benefit are substantial. I completely agree with Susan that prevention absolutely has to be done, because we can't, the numbers coming into the bucket who need treatment is going up and up and up. So we have to have prevention, but we also have to have treatment. The numbers who can stand to benefit and have better quality of life on these drugs is huge. And in no healthcare systems at the moment is the current costs at a level where they will be where they will be cost saving. So every health system is struggling to work out, or even let the kind of the floodgates open. They're just scared to let them open because they can't afford to give the number of drugs required for the number of people who want them. So it's a major issue. Once the costs come down, which I think they will do over time, they will get to a sweet spot where the cost benefits, or the benefits probably match the cost of the drugs. And I think at that time the systems will improve. But clearly, as Susan said, we need good wraparound. Things have improved over the last 5 years. There's more digital, there's a better understanding of what the questions and behavioural aspects are. But we've got a long way to go, and every healthcare system is struggling on how to best to do this. There's a long, long way to go.
Thanks, Naveed. I mean, perhaps next to Alice, the other question I was thinking about that Susan had touched upon was that the inequities that some of these medications could perhaps exacerbate existing inequities. I mean, has that been discussed much? Are there any discussions about how that could be managed?
She's right. I mean, Susan's absolutely right in that inequities can be amplified, I guess, or appear even greater. The divide gets even greater when you're starting to use therapies that are only accessible by some but not by others. And one of the solutions around that is similar to what Naveed alluded to, is around cost and then the availability of other manufacturers of these therapies, right? So biosimilar incretin-based therapies have emerged in some countries and are emerging in many other countries. And that may then allow for greater access to people. However, of course, ensuring quality control is going to be critical. So what you don't want is then to have an inferior product being given to people who can only afford a certain amount. We don't want that to occur as well. I think, though, that the upstream intervention is so critical, but that still doesn't change the biology of individuals who live particularly with significant obesity. Because I think the environmental factors, yes, can contribute a huge amount, and that's something that governments can work on, other stakeholders as well. But for those who live with significant obesity, there is definitely a biology part that we're not going to fix by government policies, et cetera. And I think that's really where these pharmacologic therapies have an incredible role.
Thank you, Alice. And then I guess one of my final reflections to Caroline. So do we think that we're escalating to pharmacotherapies too soon without addressing some of the obesogenic environment and ultra-processed foods? Is enough going on around the prevention side of things, or are we concentrating a bit too much on the medicine?
Very good question. I think we have to do both. I don't think we're escalating pharmacotherapy too soon, as we've been seeing an increase in cardiovascular disease brought upon by the changing environment. On the other hand, how do we change the environment if we haven't really found one cause yet? We do believe that it's most likely going to be maybe a combination of ultra-processed food and other causes in the environment, like endocrine disrupting chemicals. And to change that without definitive proof is a tough thing indeed, because we're really going to change the economics, really, of how we feed the billions of people on this planet, which is now, unfortunately, white flour and sugar. Let's be real. So in order to change that dynamic, we have to make sure that we're able to transfer feeding the people on this planet healthy food. And that's going to take a lot of money and a lot of time. And so I think we have to do both simultaneously, because we do have a high prevalence of obesity already, leading to disease. We've got to use the pharmacological treatments that we've discovered and try to get these treatments to people who don't have access now. But we also have to focus on prevention of obesity in the future. We're changing the practice of medicine, that's for sure.
Thank you, Caroline. And I'm conscious we've only probably got a couple of minutes left, so I just want to make sure to address a few questions in the chat. And I think a couple of questions that have come up have been around long-term data for some of the medications, and perhaps this can go to Naveed. So how long-term the safety data do we have? Because I think one of the concerns that have been raised was that some of the drugs could maybe reduce muscle mass. And so what do we know about that so far?
Yeah, no, I put the answer in the chat. I mean, clearly when you lose weight with the anti-obesity medicines, 2/3 of the weight loss is probably fat mass, 1/3 muscle mass. But it's broadly similar if you lose weight by other methodology, other methods. The question also is, and generally what happens is functional capacity generally improves because you're losing more fat than muscle, and people generally get better. But we do worry about people who start off with low muscle mass to begin with. We need more data, Chloe, going forward. Having said that, we've now got 4-year data from the SELECT trial of 3 to 4 year data, which looks reasonably promising. But with the bigger weight loss trials, we need more data. We need to concentrate on muscle. We need to look at functional capacity, grip strength, and other aspects. How people feel with these things. Generally speaking, these drugs, when they help people lose weight, what we need to then do, and as Susan kind of mentioned this, behavioral therapy, we need to empower people to then become more physically active to help to retain that muscle mass as well. And that's something that we need to capitalize on going forward as well. But absolutely, the other point I would make finally, Chloe, GLP-1 receptor agonists, not at the obesity level medicines, have been used since 2008. So we've been using these drugs for a long time. The anti-obesity medicines probably more for the last 5 years. And we haven't got 10-year data yet, but so far, generally the benefits substantially outweigh the risks at this moment in time.
Thanks very much, Naveed. And I think we've probably got time for one or two more. And another question which has come up, I think, to Alice, is just about how the liver fits into the CKM cycle.
Yeah, so I saw that question. It's a fantastic question. It fits into the M in my personal view at this point. And then I think there is a possibility of perhaps pulling it out, but to me it fits into the M because the liver is such a critical component of the whole metabolic milieu, if you will. And certainly MASLD, MASH are on that tree in terms of adiposopathy related complications. And then I think in the near future, we're going to get the phase 3 studies to look at potential interventions beyond the current one that's existing that could help, which I think is addressing the root of the adiposopathy. So to me, it fits into the M, and it works that it also starts with the letter M. So that's where I would put it, into the metabolic.
Thank you ever so much, Alice. So I think we're going to have to wrap up, but I can see that you've already all answered some of those questions that have come up in the chat. But I just wanted to ask if any of you had any final reflections that you wanted to share before I pass over to Duke to close up the webinar.
Probably we should, Susan, you should have the last word, but definitely both treatment appropriately, cost effectiveness, and prevention together. But Susan, you should have the last word.
There's no last word in this because I think this is actually, we're at the beginning. We're at the end of the beginning. I think this is a new era of effective pharmacotherapy, and that is fantastic news. It's invigorated the field. But what we are also learning is obesity is even more complicated than we ever thought, that the impact of excess weight is even more dramatic on every organ and system of the body. So, we absolutely need prevention, but that's really tough. Treatment is advancing, but oh my goodness, there's lots to learn. And I think this is a phenomenally exciting period of research, actually.
Thank you so much, Susan. Duke, are you on the call just to wrap up?
Yes, I'm on. Hi. Yes. Thank you, Chloe, for skillfully moderating that Q&A discussion, and special thanks to all participants for actively engaging with the questions. So we apologize that we couldn't get through all the questions due to time constraints. So as we wrap up this fantastic webinar, I extend my heartfelt gratitude to our wonderful speakers, Alice Cheng, Caroline Apovian, Naveed Sattar, and Susan Jett, for generously sharing your expertise on cardiometabolism. A big thank you to our dedicated marketing and operational colleagues at CellPress and the Lancet for making this event possible. And finally, a sincere thank you to our enthusiastic audience for your active participation. So shortly after this, you will all receive an email with a survey, and we would greatly appreciate your feedback. So I hope today's discussion have enriched our knowledge and inspired positive actions. So thank you.
Thank you, everyone. Bye-bye.
Thank you.
Thank you. Bye-bye, guys.